Welcome everyone, and thank you for joining us for today's webinar. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them in the question box in your GoToWebinar control panel. We have slotted time at the end of the presentation to answer them. Please look out for an email that will be sent out next week with information on how to access your CME certificates. Also, a recorded version of this webinar will be available on the SRS website in 1 week. Now, without further ado, I will turn it over to our moderator for today's session, Dr. James Sanders.
I want to welcome everyone to this 2018 SRS webinar on early onset scoliosis. Last year, under Scott Luman's leadership, we had a webinar on scoliosis casting, which was very successful, and we're pleased to expand it this year to discuss other areas of early onset scoliosis. We have an outstanding faculty for you today. Dean Andropoulos is professor of anesthesia at Baylor College of Medicine and Texas Children's Hospital, who's going to discuss an area of concern for all of us, specifically the risks which were identified by the FDA and how real these are with the black box warning that's been applied. Gregory, who's really become our official or unofficial pediatric pulmonologist of early onset scoliosis, is going to help us understand how our treatment actually affects the lungs in children. Peter Sturm is going to discuss how patient outcomes are related to our treatments and the underlying disorder for early onset scoliosis. And then we're going to have several discussions of modern treatment options, including traditional growing rods by Lawrence Haber. Peter Sturm will discuss Vector. Sumeet Garg is going to discuss definitive fusion and the Sheila, and magic will be discussed by Colin and Nnadi. And the group is then going to have 2 case-based discussions, and we're very interested in audience responses and have a place for you to respond on how you would treat these treatments too. With no further ado, I'm going to turn this on over to Dean.
Thank you very much for the invitation, and it's a great pleasure to speak to this group about this controversial area of anesthetic neurotoxicity. And let's see, I'm trying to advance my slides here. Why don't we go to the next slide? It doesn't seem to be advancing. There we go. So anesthesia in the developing brain, implications of the FDA warning for early onset scoliosis treatment. Next slide, please. I have no disclosures. And next slide. In the next 10 minutes, we'll talk about the FDA warning of December 2016, discuss current clinical studies, discuss how we advise parents about their child's impending surgery, and then address the issue of early onset scoliosis treatment and anesthetic neurotoxicity. Next slide, please. This is the FDA warning for those of you who aren't familiar. In December 2016, this drug safety communication, and by the way, it's not a black box warning, but it is a drug safety communication, FDA warning that repeated or lengthy use of general anesthetics and sedation drugs in children younger than 3 years may affect the development of children's brains, and they define lengthy as greater than 3 hours and speak about deficits in cognition, learning, and behavior. Next slide, please. So we know that about 6 million children undergo anesthesia or sedation annually. 1.5 million are less than 12 months, and 2 to 3 million are less than 36 months of age. So this is a major question with major public health implications, and we've had exponential growth of sedation procedures such as MRIs. We also know that untreated or undertreated pain definitely causes neurodegeneration and long-term neurobehavioral consequences. Next. So this disease is the inverse of most pathology in that the animal model was first and gave rise to the clinical concern, and this phenotype is not obvious from the millions of children undergoing anesthesia and sedation annually in the U.S. So I'm going to go over 3 recent clinical studies that shed some light on this question. Next. The first study is the GAS study. This was over 700 infants, less than 6 months of age, randomized to general anesthesia versus spinal anesthesia for inguinal herniorrhaphy. And then at 2 years of age, they had the Bayley scales of infant and toddler development to assess neurodevelopmental outcome. And a difference of 5 points between groups was considered clinically significant. Next, please. So we can see here in the results, in the red boxes, in the cognitive, the language, and the motor domain, there was no difference whatsoever between spinal and general anesthesia. Next. And so no difference. And can we go back one, please? The median anesthesia time was 54 minutes. The implications are that short duration general anesthesia does not increase the risk of adverse neurodevelopment, and the 5-year outcomes will be available later this year. Next. The PANDA study assessed 105 sibling pairs, one sibling exposed to general anesthesia for herniorrhaphy at less than 36 months, the median anesthetic time of 80 minutes, and the control was an unexposed sibling within 3 years of age. And then they were brought back at 8 to 15 years of age for an extensive neuropsychological battery. Next. And the primary outcome was IQ. And as you can see here, between exposed to anesthesia and unexposed, there was no difference whatsoever at all. Next. So no difference, and there was no difference in directly measured tests of memory, language, attention, and executive function. So this is good news about a single short anesthetic exposure. Next. This study, the MASS study, is what I want you to really focus on. Just published in April. This was 1,000 children tested at 8 to 12 or 15 to 20 years of age. 411 were not exposed to anesthesia. 380 had one anesthetic exposure before age 3 years, and 206 had 2 or more exposures before age 3 years. There was extensive propensity matching of all groups, and the average anesthetic time for the multiply exposed group was 187 minutes. Next. And the results are important, a complicated slide, but in the green box is the primary outcome of IQ. There was no difference between multiply exposed, singly exposed, and unexposed patients. The red boxes in the 15 directly exposed, directly measured tests, 2 of the 15 were abnormal. So fine motor function was slightly lower, and processing speed related to reading was slightly lower with multiple anesthetic exposures, but not with a single exposure compared to no exposure. And at the very bottom is a parental questionnaire. There were some differences there in the multiply exposed groups, but not in the singly exposed group. Next. So the conclusions from this study, next please. No effect of multiple exposures on IQ, that's the primary outcome. A small effect on fine motor and reading processing speed. Only 2 of 15 directly measured tests were different. The parental questionnaires had more abnormalities, but the effect sizes were small at 3 to 5%. So this is good news to me. We're not causing widespread, significant neurodevelopmental deficits with multiple anesthetic exposures. Next. So back to the FDA warning. Next. So the warning label requirement adds to all of our anesthetic drugs this FDA warning. So all of our anesthetic gases, propofol, ketamine, barbiturates, benzodiazepines now all carry this warning. Next. So what does it say? It says that health providers should balance the risk of appropriate anesthesia against risk, discuss benefits, risks, and appropriate screening, timing of surgery or procedure, and that parents and caregivers should discuss potential adverse effects of anesthesia on brain development, understand the appropriate timing of procedures that can be delayed without jeopardizing health. Next. So what is my perspective? This warning in December 2016 was really unexpected. The basis is primarily animal data. The 3 hours and 3-year-old cutoff is also primarily based on animal data. We heard that the GAS and PANDA studies of a brief single anesthetic less than 3 years of age were not associated with later neurodevelopmental problems, and at the time of the warning, the MASK study results weren't even available. Next. So I had the opportunity to write this Perspectives article expressing the concerns, and if people have time, I think I have some hopefully interesting perspectives. Next. So the National Anesthesia Societies say until additional information is available from ongoing studies, parents and providers should carefully weigh the risk and benefit of contemplated procedure before proceeding. Next. And this is endorsed by all the major anesthesia societies. Next. So our own hospital is very busy. Go back one, please. We perform over 45,000 anesthetics annually. About 14,000 are patients less than 3 years, and about 1,400 patients less than 3 years have anesthetics greater than 3 hours in length. Most of these are cardiac anesthesia patients, and we have about 14 patients annually less than 3 years who have multiple anesthetics. So this is a major issue for us at Texas Children's. Next, please. So we've developed an extensive educational resource program for both parents and providers. So this anesthesia in your child is handed out for every child scheduled for surgery or radiology or other procedures, and it addresses the FDA safety announcement along with the other anesthetic warning information. This is available on our public website, which is down below. You're welcome to look at this and even to use it, but please give us credit. We put a lot of time into this. So this has been very successful. Next, please. But the really important thing is this talking points document. So all providers in the system, anesthesiologists, surgeons, proceduralists, referring physicians, have access to this document, and it's meant to focus on 3 questions. 1, should the procedure be done now or when the child is older? 2, how long do we expect the procedure to take? And 3, will repeated or additional procedures be needed? And again, this is on our public website. Next. And the state of Texas, in the required anesthesia consent language, has now added this to the anesthesia consent. So we are required to discuss this with patients who fall under this FDA warning. Next. So what effect has this had on our practice at Texas Children's? So the talking points have been very, very helpful to distill information. The discussion frequency is increasing and it's now required. We've now done this many hundreds and even thousands of times, and parents usually have no reaction to the discussion. Many are appreciative of the information. We've had a few in-depth discussions of delaying surgery, but none really postponed. No needed surgery has ever been postponed, and essentially cancellations are delays on the day of surgery. So the FDA warning education has not had a major effect on practice at Texas Children's. Next. I want to spend the last couple of minutes on the broader question of surgical procedures and finish with scoliosis in particular. So this AAP Pediatric Surgical Task Force has been formed to discuss optimal timing of surgery. In other words, can any procedures really be delayed? And the answer, the consensus, is that many or most all pediatric surgeries are not deferrable due to critical windows for neurodevelopment and function. And so a survey is ongoing to come up with a list of non-deferrable surgeries. So next. On this list, surgeries with a critical window for repair at less than 3 years, and you can see under orthopedics is casting for early scoliosis. This should not be delayed out of any theoretical fear of anesthetic neurotoxicity. Next. And then specific to early onset scoliosis, there is this paper last year published from San Diego that assessed 16 patients undergoing growing rod treatment with final fusion, 5 were syndromic scoliosis, 8 neuromuscular, and 3 idiopathic. The mean age of the first anesthetic in this group was 7.4 years, and you can see the range of 3.8 to 11 years. The mean age of the index growing rod surgery was 8.1 years with a range of 3.9 to 14.4. And the mean age of the final fusion was 12.8 years, 9.7 to 19. So none of the patients in this series was under 3 years of age for the first anesthetic. Next. They did assess the total anesthesia time, that's in the red box there, and for the standard care procedures, as you all know very well, and as would be expected, there's a lot of anesthesia time needed for these, and for associated care for revisions, adjunct surgeries, and wound complications, a lot of anesthesia time as well. But again, none of these patients was under 3 years of age. Next. So for my conclusions, the recent FDA warning is based primarily on animal data, especially non-human primates. The MASK study is reassuring that there are not widespread large neurodevelopmental deficits from multiple anesthetics. Discussing the FDA warning at Texas Children's Hospital has been well received and not led to surgery cancellations or change in practice. And then finally, and most importantly, almost all scheduled procedures with anesthesia in young children should proceed. the benefit of the procedure outweighs any theoretical risk of anesthetic neurotoxicity, and specifically, early diagnostic and treatment anesthetics for scoliosis should proceed as indicated. Next. Thank you very much again for this invitation, and look forward to the question and answer session.
Dean, thank you very much. That was an outstanding talk. And we're going to move right on to Greg Redding talking about the respiratory consequences in children with early onset spinal deformity. Greg.
Thank you, Jim. Good morning, everybody. I'm going to talk about pulmonary disease and how it relates to early onset disease of the spine. See if I can advance this. Thank you. I think I'm going to have to ask you to advance slides too, Lauren. So I have no relationships. Next slide. When we think about early onset scoliosis, we think about spine deformities, restrictive lung disease, and progression of respiratory disease. And I've listed here kind of a Venn diagram that I think is important because not everybody with early onset scoliosis has lung disease. When you do have some impairment in respiratory function, Bob Campbell used the term thoracic insufficiency syndrome. And you begin to have thoracic insufficiency syndrome when you have an inability of the thorax to support normal respiratory function and postnatal lung growth. So the real question is, how many kids with early onset scoliosis have thoracic insufficiency syndrome, and how does it progress over time as the deformity progresses? Could I have the next slide? What happens with early onset scoliosis is portrayed here. When we measure lung functions, we know the following. We know that the lungs become small. They're constrained by the chest wall. As they become smaller, they become less distensible themselves, and so the respiratory system becomes stiffer. We also know that as the chest wall contorts, the ribs are malpositioned, if you like, and the consequence is that you have a loss of rib mobility and therefore a loss of chest wall expansion, and really what you get is a stiffer chest wall. So kids have to work to breathe, and the way I describe this to families is that if I wrap a belt around your chest and I have you climb 10 flights of stairs, you will start to feel restrictive lung disease, and that's what happens to these kids. As their chest wall deforms, they lose the function of their intercostal muscles, and as that occurs, they become increasingly reliant on their diaphragm. And what we've learned recently is that the diaphragm itself, because of its distortion in its attachments to the chest wall, it turns out to function less well than we thought, and you actually develop a loss of diaphragmatic force generation and more fatigability. Next slide. The consequences of these changes include diminished cough, so the children have longer illnesses when they get superimposed respiratory viruses. They have probably more risk of anesthesia complications from a pulmonary perspective after surgery. They clearly have diminished exercise tolerance, and that's probably the first thing to occur. A few have a torquing of their mediastinum, and what I've shown you on this slide with this CT scan is how the major airways are compressed by the mediastinal contents and the vertebra. This occurs in about 10 to 30% of kids with early onset scoliosis. We don't have a good handle on it, but it's a minority of kids. And if you have severe disease, you are likely to develop pulmonary hypertension, particularly if you don't watch how they breathe during sleep. During sleep, they have the most frequent episodes of hypoxemia due to low lung volumes, and that recurrent hypoxemia leads to pulmonary vascular disease and pulmonary hypertension. And obviously, when all this progresses to the endpoint, you get hypercapnia and respiratory failure. Next slide, please. How does this clinically manifest? Well, if you don't have pulmonary functions available, you start asking about things that parents may appreciate. We know that abnormal lung compliance occurs in more than chest wall compliance occurs more than 90% of kids. You get a reduced chest wall excursion, although we don't measure that very well. And what those things really manifest as is exercise intolerance. So one of the first things you ask about is a standard form of exercise like walking up a flight of stairs or 2 flights of stairs or riding a bike up a hill is something kids do as they continue to grow. And if they can't do it because they have progressive restrictive disease, they stop doing those activities or they stop and rest. And that becomes a serial monitoring measure for us clinically. We know 90% of kids have sleep-related hypopnea, which means they breathe shallowly, and as a result, they tend to get hypoxemic when they sleep. This is very common and much more common than we originally thought. We're trying to rethink this in terms of how we monitor for children. When you measure vital capacity, about 60 to 70% have a reduced vital capacity below normal at 80%. And if we look at how their lungs work, you can actually hear this with your stethoscope. You can hear a difference in the right versus the left side in about 50%. About 50% are overtly malnourished with a BMI of less than 5%, and about 20% have high hematocrits if you study these, particularly if you're not paying attention to the hypoxemia during sleep. Could I have the next slide? So what do we encounter? This is a very important slide because it tells us what lung function is like at the first encounter. And you'll notice on this slide that the early, on the left-hand column, there's a lot of blanks. And that's because kids under 5 years of age don't do pulmonary functions. And so when we measure them, we're starting at about 5 years and continuing. And what you see here is a dramatic variation in the degree and severity of illness and compromise as measured by vital capacity when kids first are encountered in a spine center. This is data from Seattle, Philadelphia, and San Antonio. And what's very important about this, and the message I want to leave you is that right now, what you see in terms of initial evaluation and vital capacity is probably what you're going to try and shoot for to maintain for the rest of the child's growing years with all the devices that we currently have in place. There's very little evidence that we actually recoup lung function after we first see a child before we start therapy. And for all the therapies we have, there's no evidence that we actually improve things substantially. Could I have the next slide? We know that there are structural improvements as a result of our devices, reduced Cobb angle, reduced kyphosis, depending on how you contour the rods. We know there's increased vertebral body growth and increased thoracic height, and all of those are thought to be good things. Could I have the next slide? If you look at lung volumes, however, and we're talking about lung function, and again, this is in kids old enough to do the pulmonary functions, you find that the vital capacity, the first column there is normal. The second column is what happens preoperatively. Kids come in, they have restrictive lung disease, they have a reduced vital capacity, and residual volume is that volume in your chest that's left when you blow out everything you can blow. And vital capacity is more compromised than residual volume simply because the chest wall is stiff and you can't blow out when you have a stiff chest. If you look at what happens 18 months after, and this was after the vertical expandable prosthetic titanium ribbon specifically, there was a reduction in vital capacity by about, not quite 10%. Residual volume actually went up. And so we interpret this data to suggest that you actually make a bigger box, but that it's stiffer. Next slide. If you look over 6 years, there are 2 series, one published, one not. The first is from Pittsburgh, the other is from Seattle and San Antonio, and they show similar kinds of things. They're measured under different conditions, but importantly, if you look at vital capacity over a period of 6 years, there's about a 28% reduction in vital capacity in the Pittsburgh group, and in the awake group from Seattle and San Antonio, there's about a 16% reduction. These may be important differences based on how the tests were measured, but it's important to realize you don't keep up with lung growth as it's measured by somatic growth as a percent of predicted vital capacity. So leaders come up, your absolute values come up as kids grow, but the percent predicted declines slowly, even with surgical therapy. Next slide. This is the only study I think is of interest that we have out there on long-term follow-up. Just recall that the devices we've had in place for growth-friendly constructs have only been around for about 10 years. So what you see here is that in children who had early onset scoliosis and underwent spine fusion as their only therapy and were followed for 25 years thereafter, that those children who had a vital capacity less than 70% actually had a significant decline as they grew older. Those are the triangles that you see. And I think the important messages here is that your early onset scoliosis produces early onset lung disease. And that lung disease is one that you can preserve with what we currently have. It prevents progression. But in actuality, we're not gaining anything over time. We're not recouping lung function. And that the children who have the worst lung function are likely to have decline as they become adults. And I'll stop there and answer questions later. Thank you very much.
Greg, thank you. Excellent talk. And we're going to move on to Peter Sturm, who's going to discuss with us the outcomes in children with early onset scoliosis. Peter.
Thanks, Jim. Thanks for inviting me. And Lauren, I think you're going to have to make me go as well. These are my disclosures. Next slide, please. So I think when we discuss what we're doing for families and what we're doing to kids, we need to be very careful that we don't discuss our treatments in a vacuum. And I think having Greg speak before me was very good because Greg, Lauren, want to go back again for 1 second, please? Because Greg pointed out what this really is all about. This really is not about the spine. It's about the lung. It's about what the spine is attached to, which is the chest. And we know that big curves in little people are an enormous problem. Next slide. We know severe curves affect space available for lung alveolar growth. And Greg can address this obviously much better than any of the rest of us can. Next slide, please. We know there are good natural history studies in early onset scoliosis. Davies and Reed's study out of London, decreased alveoli, decreased small blood vessels, atrophy of the pulmonary parenchyma, increased work of breathing, abnormal ventilation perfusion ratios in these people as they get older. Next slide, please. And Brathwaite's study, curves diagnosed before age 5, 11 of 15 had significant cardiorespiratory disease. Curves diagnosed after age 11, 6 of 28 had a significant cardiorespiratory disease as adults, but 5 of these 6 actually had cardiorespiratory disease based on cardiac disease alone. So having early onset scoliosis untreated is a significant medical problem, as we know. Next slide, please. And I think this is the best slide. I'm sure everybody who's on the call has seen this slide before. Adolescent idiopathic scoliosis, the expected and observed death rate is the same. Juvenile, it starts to change some, and in infantile, it changes significantly. So when we talk about what we do to affect these families, we need to think about the effect of the disease itself on these families if it's not treated. Next slide. So what do we know about these EOS kids and quality of life scores? So quality of life scores are among the lowest observed in all of pediatrics in the early onset scoliosis kids, and this is in the untreated kids. So quality in kids, Vitali's study in IMAS and in spine has shown significant impact on families. And remember that when we talk about health-related quality of life, we're not really talking about the kids because they're not the ones who are answering the questions. It's the families themselves and the parents. So having kids who have early onset scoliosis is a huge burden and has a huge impact on families. Next. So how do we measure the impact of our treatments both individually and societally? And I think the second point is something that we don't talk about frequently, but I think in the future, as medicine continues to change, payment systems change, this is something we're going to unfortunately have to address more and more. Next slide, please. So obviously, it's no longer just about x-rays, and it always amazes me when we go to our meetings and people do studies and show x-rays and talk about Cobb angles, and it's really not about the Cobb angle or the x-ray anymore. It's really about what we're doing to these kids pulmonary-wise and what we're doing to the family's quality of life. So there are various ways to measure this. We need to assess the impact on families, and really we need to look at the whole picture for these kids and these families and not just numbers of spine deformity. Next slide, please. So does casting work? Yeah, casting does work, right? There are multiple studies with excellent results. Jim and I had a study published where we looked at the effect of casting on kids with early onset infantile idiopathic scoliosis. Casting started early, works well. And this is one of Jim's patients before and then after cast treatment. Good study out of Shriners in Chicago, looking at the effect of cast treatment, and casting again, and especially in the idiopathic kids, works well, and in the syndromal and neuromuscular kids, works well as a holding action to try to put off surgery till later on. Next slide, please. But we know a couple of things, and Dean addressed the second one very, very well. And I think that he really brought up some very salient points. The risks of not treating these kids are certainly outweighed by the benefits of treating them. So I think that there's no question in my mind that this is a discussion we need to have with families, but the evidence, the preponderance of the evidence is that treating curves early is the right thing to do. But there's also a good study out of Columbia that shows that casting an early onset scoliosis decreases quality of life compared to controls and increases the burden on the caregivers. Now, the question is, should we really be looking at the quality of life compared to controls? Because normal, healthy kids are very, very different, obviously, than kids with early onset scoliosis. When we're doing these studies, we're really comparing the appropriate groups. Next slide, please. Growing rods. Similarly, you will hear some more later about the different treatment options. But we know growing rods in general, and not this is across the board, have an exceedingly high complication rate. Shea Bess's study in JBJS, 58% at least one complication, 13% decrease for each year later, 24% for each lengthening increase in complication. And in Baruz's study, one of the early studies looking at growing rods, 48% complication rate. So complications are extremely, extremely high. Next slide, please. And we also know that, but when we look at some of the studies that are out there as far as quality of life, again, study out of Columbia, the initial study showed improved quality of life at 6 months after growing rods, despite all of the downsides to it. Next slide, please. But over time, we also know there's long-term increased caregiver burden and a decreased quality of life compared, again, to age-matched controls. Interestingly, there's one study that I'm not sure has been published yet. I think it's still an unpublished study out of England. Sean Marks and the people in London looking at increased sports participation in kids, in early onset kids who were idiopathics who had growing rod instrumentation. Now, I think that's kind of an outlier, and I think most of the studies show that while we are treating these kids, we are definitely increasing the burden on these families. Next slide, please. We were hoping that magnetically controlled growing rods maybe would change this equation. Unfortunately, the last few studies that are out there show that there's no appreciable difference in health-related quality of life measures between traditional growing rods and magnetically controlled growing rods. We're hoping to see that taking kids to the office and doing a lengthening in the clinic as opposed to doing lengthening under general anesthesia every 6 months would make an enormous difference. And unfortunately, that really does not seem to have held up. Next slide, please. We also need to look at some other considerations when we look at caregiver burden, which are financial. Good study out of San Diego a long time ago looking at femur fractures, showing that operative treatment costs were comparable and less lost parental work time versus kids who at that time were treated in femoral traction for fractures for long periods of time. So the question is, does this really hold up with multiple trips to the OR for our kids with early onset scoliosis? This is a study that's not been done yet that I think is really important to do going forward. Next slide. And I think future metrics, what we're going to have to look at more and more is the value of what we do. Porter has come up with this algorithm with a value treatment, which is the outcomes over the costs. And I think this financial burden societally is going to need to be looked at as well. Next slide. And I think so the other thing is, as Greg said, there really are no good pulmonary studies. So are we doing the best we can for these kids surgically, or is the medical pulmonary management as important or more important than what we're doing for these kids? And as Greg pointed out, better x-rays and better space available for lung may not equal better function. Thank you.
Peter, thank you. Very informative there. Our next set of discussions are going to be on our current existing modern treatments for early onset scoliosis, with the exception of the non-operative treatment. So we're going to discuss all of the various operative treatments that we believe are current. We're going to start out with Lawrence Haber, who's going to speak with us about traditional growing rods.
Okay, good morning, everyone. And first of all, I actually left a very important indication for traditional growing rods off my list, and that's the ability to afford them. So there's certainly areas where the affordability of attaining these rods is an issue and that they're not accessible. So certainly with those situations, it's important to remember that traditional growing rods were much better than natural history in these kids or early fusions. So it's not a completely dispensable technique at all, even in more typical situations. This is actually a child that had a long run on traditional growing rods, and this might be my definition of traditional growing rods, but we typically, if we could, would leave them long off the bottom and then lengthen them off the bottom, just loosening the 4 pedicle screws and distracting. And then you can see this child through about a 6-year run eventually outgrows those, and we put connectors in the middle and use those to finish his lengthenings, and then finally ending up with a fusion at the end. So certainly for this child, despite the anesthetics and the other issues that we have with these children, had a much better course than he would have untreated. I'm going to go back here. My disclosures. So when do we need traditional growing rods? I think most of us would agree that if there's the opportunity to use an automatically or internally lengthening rod, that's a better option than going to surgery every 6 months. But there are indications for using traditional growing rods. Magnetically controlled growing rods are often too large to put under some of these children's skin. Certainly when we're working with small children, with syndromic children, with children with nutritional challenges, that can be an issue. Part of that is due to the bulk of the actuator. It's definitely more difficult on the convex side. This is a patient with a low-level myelo, or actually a high level. Her defect is up around T12L1, but actually has good function and is an ambulator, who we went in to do magnetically controlled rods on with a rib distraction to pelvis construct, and there was no way to put anything on the convex side. So in her, we have to make a decision. Do we want to do something more traditional, or do we want to do a magnetically controlled rod and just do a single rod? So that's certainly a situation we have to deal with. Maybe there's other options out there. Maybe there's an option of putting a trolley on the other side of something or something of that sort. But the point is that a lot of times in these magnetically controlled rod constructs, there's just not enough tissue to get a rod on that convex side. Can you switch that one for me, please? Curve stiffness can be an issue. There's only so much torque you can put on a magnetically controlled rod, and they don't always provide enough force. This is a child with neurofibromatosis that had about 130-degree curve, and we just felt like we needed the extra force to keep her straight. There are other issues that we'll discuss about her in a second, but certainly for large rigid curves, some studies have shown that when we go from rib-based constructs to convert either staying rib-based or spine-based, but convert to a magnetically controlled rod, that there's not enough force. There's other studies that say that that's not true, but that is a concern. So certainly when you need more force, sometimes you have to convert more to a traditional growing rod. Kyphosis is an issue. So any abnormal sagittal plane alignment or significant sagittal plane alignment can force you not to use a traditional rod, or not to use a magnetically controlled rod. The reason is you cannot bend it across the actuator. It's only a limited area that you can bend. And certainly that was true with this type of rib-based device also, but with more traditional rods, sometimes you can work around that. And certainly if you use the rods long off the end, it gives you much more variability in bending your rods to match the patient's sagittal alignment. And then finally, in some children, MRI is an issue. There are studies now. There was one in spinal deformity last month by Woon and the study groups showing, again, that MRI looks to be safe in these children with magnetically controlled rods. And most of these are tested on 1.2 or 1.5 Tesla MRIs for about 15 minutes was the original study that was released by the manufacturer. In that study, they showed that for 15 minutes with a 1.5 Tesla MRI that there were no issues. There was some heating, but not enough to be problematic. Unfortunately, some of these children do need higher resolution MRIs. And actually, the child that I showed a few minutes ago with the neurofibromatosis, and in this child as well, there were brain lesions that are being watched and they need higher level MRIs. And in those children, we don't know if it's safe or not. And even in the lower Tesla MRIs, our data is pretty limited. There was, this past survey that was released in Spine Deformity in a study by the same group showed that about 10 children that it worked well in, but they're not high numbers. And all those children, there was no malfunction. The rods, everything seemed to work well afterwards. Lengthenings were successful afterwards, and there was no injury from the MRIs. So we think that it's very safe in these 1.5 Tesla MRIs, but time will tell, and more research needs to be done to see if we can do higher Tesla or higher density MRIs in these children without affecting their treatment. And so this really turns out to be an issue in kids with neurofibromatosis, kids with tumor issues, and in these situations certainly should consider a traditional growing rod. So basically, the main reasons to consider a traditional growing rod over a magnetically controlled rod is patients that are too small to cover the bulk of the larger rods, rigid curves, conversions from other devices, kyphotic patients or patients with highly abnormal sagittal plane, and when high-resolution MRIs may be needed in the future.
Lawrence, thank you very much. We're going to take a quick pause for a second. And Lauren, can you introduce the poll that we would like people to respond to? So if people can please respond to, this is the case-based one. Lauren, can you go to the other poll, please? I think we may be struggling a little bit here. So if we can ask you to respond to this we'll give you a few seconds here to do this. All right. Let's go on to the next question, please. You guys are great rapid responders. And let's do our next question. Actually, let's hold off on that one until we go through our next set of talks here. So we're going to go on at this point to Peter Sturm, and we'll return to our discussion about vectors. Peter?
Thanks again, Jim. Lauren, you want to take me to the next one, please? So Greg already had discussed thoracic insufficiency, which is the inability of the thorax to support normal respiration or lung growth. Next. So the vector was originally designed to treat volume depletion deformities of the thorax, which cause thoracic insufficiency syndrome. Next slide, please. And I think this has been Bob's biggest contribution to this field, is really getting us to think about the chest and what effect that has long-term rather than on just the spine itself. Next, please. Next slide. So initially, rib-based growing constructs were introduced to treat congenital curves with fused ribs and spondylothoracic dysplasia syndromes. Next slide, please. So this was the initial indication for treatment: congenital curve, fused ribs. Next slide. And rib-based treatment, doing a thoracoplasty, opening up the chest on that side. This is what vectors and rib-based treatments were all about initially. Next slide, please. And also kids with these spondylothoracic dysplasias like June syndrome, where we hopefully can expand the chest and grow the chest as these kids grow, having nothing at all to do with the spine. Next slide, please. We know that there are reports that these devices work well. In congenital curves with chest abnormalities, a couple of Bob Campbell's series, space available for lung increased from 63 to 80% in one study, and in another study they even reported on the growth of unsegmented bars when there was distraction across the bar with rib-based systems. And Jed Carlin's study in JBJS in spondylocostal dysplasia treated with rib-based systems showed improvement in the natural history as well. Next slide, please. We then have taken this, though, to expand this to secondary thoracic insufficiency syndrome, where we talk about respiratory compromise secondary to the curve itself. And this goes back to Greg's Venn diagram. Next slide, please. So where are there secondary insufficiencies, and when should we be thinking about using these systems? I think there are a couple that are well suited to using it, and others that it's very much more questionable. So we'll go through myelodysplasia, SMA1, and EOS separately. Next slide, please. So in SMA1, ostensibly, you have potentially better control of the parasol deformity, which we know they all get. And the question really is, do we get improvement in these kids' pulmonary functions, or do we get maintenance of their pulmonary function? And the studies seem to really show that we can certainly improve their curves, and we probably can maintain their baseline respiratory function and guard against deterioration to some degree, but it still remains very questionable about how much improvement we get. And the other thing is, we are probably looking at a condition that more and more will become medically managed rather than surgically managed. Next slide, please. So this is a typical SMA1 kid. These extremely, extremely small chest, parasol deformity of the ribs. Next slide. And I'm sorry that doesn't project all that well, but so this is a vector on that, rib to pelvis. And the good thing about this is that you can attach the ribs to the device. So what we do is we put Merceline tapes under each rib, try to pull the chest up to the device, and as we expand the device, we hopefully expand the chest and correct the parasol deformity as we go. Again, whether that really affects their pulmonary function to the degree that we would like remains very, very questionable. Next slide, please. Myelodysplasia, I think the great advantage in these kids is that you can avoid the midline in the early onset kids. So you don't have to expose their meningocele. You don't have to look for posterior elements or even pedicles that don't really exist. You can fix to their pelvis, and then you can fix to their ribs or to their spine. I actually prefer this construct because I've become more and more convinced that because of the play with the ribs as they attach to the spine, that you don't control deformity as well with spine-based constructs as you do with rib-based constructs. Excuse me, the other way around. That you don't control the deformity as well with rib-based constructs as you do with spine-based constructs. Next slide, please. Again, the problem is in myelodysplasia, functional improvement with instrumentation really still remains unproven. Next. So the early onset kids, we know about the law of diminishing returns. We know about people supposing that we get autofusion when we have rods in for a long time and we distract. So rib-based constructs were put forth as a way to guard against that and to guard against stiffening of the spine. Next slide, please. So this is an otherwise normal kid with an early onset curve, and this is the construct that was put in. Next slide. So the question is, can we really control the curve magnitude as well with the rib anchors? There are studies that show that we can. I'm not sure that that's really going to hold up over time. Again, I think because of the way the ribs attach to the spine, you don't really get the same forces across the spine as you do when you have spine-based anchors. Next slide, please. And again, the biggest concern I think I have is that, are we trading spine stiffness for chest wall stiffness and diminished pulmonary compliance, and really getting to a situation, as Greg alluded to, where we have a bigger box, but it's just the same black box, only bigger? Next slide. Thank you very much.
Peter, thank you very much. We're going to move on to Sumeet, who's going to speak to us both about when is it fine to go ahead and do a definitive fusion, and also discuss with the Schilla. Sumeet?
Thanks, Dr. Sanders. My disclosures are noted. I have taught in the past at courses by Medtronic that teach Schilla growth guidance, which we'll be discussing in a little bit. So the indications for a short fusion predominantly are related to short angular deformities. So these are cases where in a span of perhaps 2 to maybe 4 or 5 segments, you can get 3-dimensional near full correction of the spine that is hopefully long lasting. So for example, this isolated hemivertebra in a young child. It is also indicated, so the slide, there we go, in sharp angular kyphosis, either with myelopathy, where I think you have to do something, or an impending myelopathy, can also be indications for a short fusion. Hemivertebral excision, as I mentioned, you really want to make sure the curve is progressive. Some of these, especially those that are incarcerated, may not actually cause a progressive deformity. So it's important to watch for a little bit, not jump too early. I find generally by age 2 to 5, I've identified that it is a progressive curvature, and that's a size where the spine can support pedicle screws, which allow for this 3-dimensional large correction. The spinal cord is also fairly robust in toddlers. You are doing a circumferential osteotomy, including soft tissue of the discs, the bone, and working around the spinal cord. So it's helpful to do this at a younger age to minimize neurologic injury, and as well as allowing for quicker recovery if you do sustain a neurologic injury. This is an example. A child over the course of 6 to 12 months did demonstrate progression. The image on the right is a 4-year-old girl, and you can see that curve is progressing. And we felt that we could get a very straight spine with a hemivertebra excision. 3D CT, I think, is invaluable when you plan these cases out. It lets you see the anatomy both from the front and back, plan your anchors, and also keep you safe on your exposure. In this case, it's fairly straightforward. The hemilamina does correspond to the hemivertebra. This is another case that should pop up. If you follow that yellow arrow, you see the hemivertebral body. But as it spins around, it does not correspond with the hemilamina on the back. If you don't have this information, you can get yourself trapped and perhaps be doing wrong level surgery. As you can see, the hemilamina on the back actually corresponds to the level above. I prefer to close these with a central rod to avoid strain on my pedicle screw. So you can see here, after establishing my anchors, you can do the osteotomy and then use laminar hooks to close this down. This has been reported by several authors. Found it to be a very safe and effective way to correct these deformities. And here you can see a 2-year follow-up. We have a very nice straight spine with a appropriate sagittal contour. So I think this is one where we still need to follow her, but very likely this patient will not need further treatment. There are numerous case series published for hemivertebral excision, but they're all very low evidence, level 4. In general, the complication rates are low in experienced hands, but we don't know what happens down the line. I've cited here below 3 of the larger series that have been published for your reference if you want to read more. We're going to shift now to growth guidance. This is a FDA-approved technique. Growth guidance really relies on apical control using a short segment fusion with pedicle screws, often with posterior column osteotomies, and in some cases even asymmetric pedicle subtraction osteotomies or VCRs. And using growing screws at your upper and lower foundations, and these should be done with limited exposure. As you see, the set plug in these types of screws does not actually lock onto the rod, only onto the screw, allowing for some slide as the spine grows. When you do your growth screws, you want to use small fascial incisions and percutaneous technique to try to minimize the chance of developing a fusion at your upper and lower anchors. Fluoroscopy is helpful. These are some images from Dr. McCarthy with fluoroscopic images. Many surgeons who have navigation available have also been using this to help place your growing screws with limited exposure. Here's an example of a 9-year-old boy with a large curve. A very active child, wanted to be able to play basketball, and did not want to be coming in frequently for expansions with a magnetic controlled rod. So you can see we used 4-level apical fusion and then placed growing screws above and below. The yellow box shows the areas of apical fusion, and the blue box shows the growing screws. You generally leave the rods about 2 to 3 centimeters long on either end. Largest reported series is from the developer of the technique, Dr. McCarthy, with 40 patients with 5-year follow-up. There is a very high complication rate, 73%. Majority of these are implant-related problems. And while that seems high, we know that rib-based constructs, traditional growth rods, and magnetic growth rods also have very high implant complication rates. Overall, he identified similar increases in thoracic length and Cobb angle improvement compared to growing rods. There's one match study looking at traditional growing rods versus Schilla growth guidance from the Growing Spine study group with 4-year follow-up. And they found a similar complication rate. They found more growth in length with growing rods versus Schilla, but better Cobb improvement with Schilla. Schilla did have less surgeries because you don't have planned expansions like you do with traditional growing rods. There are no studies I'm aware of comparing Schilla growth guidance to magnetic controlled growing rods. Thank you.
Sumeet, thank you very much. And we're going to go on now to our last straight didactic with Colin Nnadi speaking to us about the magnetically controlled growing rods. Colin? Colin, you there?
I think Colin might be having some issues with his sound right now.
Okay, then let's go ahead and do a couple of other poll questions here. The first one we're going to go to is which instrumentation type is associated with fretting corrosion? All right, let's go to our next question now.
This one here?
Yes.
Okay.
All right, well, let's go back and see. Is Colin, are you ready yet?
Can you hear me now?
Yes.
Yes, we can hear you. Awesome.
Yeah, okay, right. So my name's Colin Nnadi, and I've been asked to talk to you about whether the magnetic growing rods are the solution for early onset scoliosis. So next slide, please. So those are my disclosures. Next slide. So traditional growing rods have been the mainstay of treatment until recently for early onset scoliosis, but as we all know, the main drawback has been the need for repeated surgeries. Next slide, please. Next slide, please. So that's what the magnetic growing rods look like. And incidentally, the picture at the bottom shows one of the original flexible rods to try and get around the difficult problems with acute curves, but they seem to have disappeared recently. So next slide, please. So that's the external remote controller, which is used to distract the rods. Next slide, please. And then the picture on the left shows what we used to do, and then on the right shows what we do now. So I think you'd all agree there's a big difference. So next slide, please. So I thought, but I'll just go through our experiences here in Oxford with the rods to give you an idea of what the indications are. So the first study was just under 2 years when we looked at 19 children. And looking at the radiological results, which were comparable to those that you find with the traditional growing rod systems. Next slide, please. We then set up a National Institute of Health Research study in which we observed a group of children over a 2-year period. Next slide, please. So the aims of the study were to basically assess the safety and performance of the magnetic growing rods. Next slide, please. The inclusion criteria, which all children aged between 2 and 10 years with early onset scoliosis, and that the surgeons felt would benefit from the magnetic growing rods and had to be of an appropriate size. Exclusion criteria were patients who'd had prior construct problems, those with post-operative wound infections, or conversion patients with more than 3 previous distractions. Next slide, please. And then it was a heterogeneous group, as you can see from the letters in red below. Next slide, please. And the main task that we were landed with was to determine whether the rods were actually safe to use. So what we were looking for was to see if there were complications, were they conclusively related to the rods. Next slide, please. So 5 out of 10 patients had complications, but the key thing is none of the complications were conclusively related to the device. Next slide, please. In terms of cob angle correction, it compared favorably. Next slide, please. And also radiological markers such as the thoracic and lumbar column lengths were comparable to what's been published previously. Next slide, please. In terms of the growth parameters, sitting and standing height as well as weight improved over the course of the study. Next slide, please. And then we looked at functional outcomes again, and there was improvement across most of the domains. Next slide, please. So in summary, there were no device failures at 2 years. The device was safe to use, and there were no infections. Next slide, please. So we've recently looked at our 6-year series, and again, a heterogeneous group. But then this time there were 16 primary procedures and 15 conversion cases. Next slide, please. And the results, again, from a radiological and clinical point of view, are comparable to what's been published previously. Next slide, please. But in terms of complications, 67% of our cohort developed complications. There were 70% unplanned returns to theatre, and 22% device-specific complications. And most of the conversion cases developed complications. Next slide, please. So we did a risk analysis, and may I just point out that there is precedence for revolutionary medications or devices to have a risk profile. So the magnetic growing rods aren't unique in this instance. Next slide, please. So in terms of the complications, across the radiological values, the complication group did worse. Next slide, please. We looked at the clinical parameters as well, and again, the complication group of patients tended to be worse off than their peers. Next slide. And then sorry for the busy slide, but that's just a depiction of the various clinical parameters over the 6-year period. Next slide, please. And again, we looked at the functional outcomes and tried to match them against the variables to see if there was any correlation, and I think age was the main one. So next slide, please. We looked at the complications. The mean time to complications was about 35 months. Next slide, please. Next slide, please. And then again, in terms of function analysis, the complication group did worse. Next slide, please. And then again, with the demographics, it was really a question of the older patients tended to do better and have less complications than the younger patients. And the age of 7 was the cutoff. Next slide, please. So metallosis, and in the next slide, the pin breakages were the complications that we were most concerned about. Next slide, please. And they have been written about previously. Next slide, please. So we did a systematic review looking at what's out there. Next slide, please. And we looked at the general complication rates and then unplanned returns to theatre. Most of the studies were heterogeneous. Next slide, please. And then very low level evidence as well. Next slide, please. And then that's a list of all the papers that we looked at. There were 12 in total with about just over 300 patients. Next slide, please. And then we summarized all the articles, and the complication rates varied from 0 to 100% in each of the studies, so depending on which ones you looked at. Next slide, please. Again, that's just a breakdown of the commonly reported complications. Next slide, please. And then we compared the primary and conversion groups, and there wasn't actually a significant difference between the two groups. Next slide, please. So in summary, the cumulative non-medical complication rate is about 44%, and there were 33% unplanned reoperation rates. Next slide, please. We're just finalizing. But however, when you compare this to previous reports by the Barusat-Barnia group, it actually compares quite favorably. So I think I'll stop there, but I just hope that taking you through our experiences with the magnetic growth rods will give you a fair idea of which group of patients that we would tend to use them in. So what we found was that those patients over 7 with dual rod constructs with primary surgery tended to do better than their peers. Thank you.
All right, thank you, Colin. So we're going to go on to a couple of cases here to present to the various moderators. The first case here is a 4-year-old girl who came, she had a prior VSD repair. MRI showed that she had a small syrinx that really was not large enough to operate upon. She did not have a QRI malformation. There's no evidence on any of the films that she had a vertebral body malformation. She's neurologically intact, and she shows up. She's playing very nicely, communicating quite well. And so I want to go through a few different questions, and we're going to put up a poll for the audience also while we're having the case-based discussion. If you can please, Lauren, put up our first question that said closed on the poll, but if we can go to that and reopen that again, please. if it's feasible to do so. And I'm going to start out with a question for you, Dean. This girl, she's age 4, and she has very little risk from what you're telling us if she's over age 3. Is that correct? Is she fine now that she's age 4 as opposed to age 3? And do we have concerns, and what should we be telling families at her age and with what we need to go through for her? So, Dean, can we get you back on here?
Hello, can everybody hear?
Yes.
Yes, the 3-year-old cutoff is a best estimate, I would say. The human data for the 3-year-old age cutoff is very weak. There are some studies showing some effects over the age of 3. From the animal studies were pretty convincing that the younger the animal, the more injury from the anesthetic there would be. So this 3-year-old age cutoff is somewhat artificial. If you're 4, are you completely out of the woods in terms of any concern about this? Well, not necessarily. But again, treatment for this very significant condition outweighs any theoretical risk. At age 4, we are following the FDA warning. We're not really talking about anesthetic neurotoxicity risk at age 4 unless the parents ask. Our efforts are focused on those under the age of 3, but the evidence for that is not very strong.
And Greg, are we going to help her lungs, and how are we going to know? And Lauren, can you show the prior slide, please?
So my feeling is that you're going to preserve what she's got. I'm not sure you're going to help them much, but you're going to prevent the progression. I think it's important that the earlier you intervene, not necessarily with titanium struts, but the earlier you intervene, more likely than not, you're going to preserve what she has as she continues to grow.
And how will we know that we're actually preserving her lung function over time and that it's just not getting worse?
Well, I think in this kind of child at 4, you're hitting kind of the weak spot of pulmonary assessments because they're too young to do pulmonary functions reliably. And you're going to have to go with clinical manifestations. And what we look for most is to look for whether children are tachypnic, whether they use their abdomen to exhale and push, and whether or not they grow. And not all those are very specific, and I'm not sure how sensitive they are, but if you have those issues and you can identify them clinically, then I think you follow them over time. It's not clear to me they're going to improve over time, but until they get to 5, you're pretty much stuck with clinical observations.
And Lauren or Courtney, if you can please move us to the previous slide so people can see the case under discussion here. And I'd like to ask each of the panelists, let me just go through with each of you kind of in order here. And we'll start out with you, Lawrence. How would you prefer to treat this little girl here? With non-operative, Vector, Sheila, traditional growing rods, or magic? And Lauren or Courtney, can you again help us with the slide, please?
Sorry, what slide would you like up?
The previous slide, the one on the 4-year-old girl, please.
Okay, I think that's the one I have up right now.
We have the 9-year-old girl up right now. Can we move, just go one slide prior, please?
Courtney, can you try to move the slide back to case 1?
I'm having trouble with that. I'm not able to move it.
Okay, so if everybody remembers what that looked like, it was a 4-year-old with a kyphoscoliosis and sternal wires in. So one thing is that these are very difficult children to treat. I really think some of these kids that have had previous thoracic surgery have a tether in front and have abnormal growth in front in the sternum. So kyphosis becomes a major issue. In my hands, it would be time for surgery at this point. If I think she's progressing, if I think her deformity's been stable for a while, I might try to hold out and wait. I think anything you do is going to be somewhat problematic because of her kyphosis and because of the inhibited growth anteriorly. But she would likely get a magnetically controlled rod system. I would probably give consideration to doing rib based on her, but spine based is more typical. A lot of that depends on how normal I think her spine growth is. If it's someone with more of a congenital deformity, and I think that they're going to already have inhibited spine growth, a lot of times that's the type of child that I'll go out and fixate on the ribs. But whatever you do, you're going to have to get high and get up around T2 and do your best to control her kyphosis.
Peter, your thoughts?
So I think I agree with Lawrence. This is a very difficult case to deal with, and I think whatever you do, you have to be very honest with the family going in that your complication rate is going to be enormous. You would like to wait if you can, but I'm not sure you're going to be able to if this has been progressing. I think it's going to continue to progress. This kid is, to my mind, is a good kid for halo traction preoperatively to try to get as much correction of the kyphosis as you can and to get her scoliosis as corrected as possible before you put in any kind of rods. I think you definitely need to get up to at least T1. And these are the kids that I think we should probably start thinking about going into their lower cervical spine with instrumentation to try to guard against proximal junctional kyphosis, because you know that's going to happen and that's going to be an enormous problem. And I think that in a kid like this, I think getting in with this degree of kyphosis, getting in magnetically controlled rods is very difficult. So to my mind, this is still an indication for traditional growing rods.
Sumeet, your thoughts?
I agree with our prior speakers. I think the kyphosis and the small age and size are the biggest challenges here. Understanding whether it's progressive and how progressive will be important, but I always try to delay when kids are this small. I would do a trial of halo traction. It looks like there's some fair flexibility in the frontal plane. It'd be interesting to see how much the sagittal plane corrects with halo traction, and perhaps after a period of traction for 1 or 2 months, consider a trial of casting to see if you can buy some time and just hold things to allow the child to get bigger. If you do have to go to surgery, I do think magnetic rods would be difficult given the size and the kyphosis here, and this may be one where traditional growing rods are required.
And Colin, your thoughts? I think Colin's facing some challenges with his sound today. So just what I've tried so far, and I won't go into anything further, is I did put her in halo traction for a period of about 3 months, and I'm trialing some casting. I'm not sure I'm going to succeed, and then I'm going to have to go through one of the options that you guys mentioned, so I appreciate all those thoughts today. Let's go on to our second case. Colin, you back?
Yeah. Can you hear me?
Yes, your thoughts, please.
Sorry. No, I'd started to speak. No, I said, first of all, I would get a CT scan to define the bony anatomy, because then that determines whether I'm going to use screws or hooks to fix it. And then I agree with the previous speakers about halo gravity traction, but I would use a magic rod, and I would use a single rod construct on the concave side, because I've done that before and it's worked. I'd use a 5.5 rod and try and get screws, bilateral screws proximally and distally with a single magnetic growth rod.
Well, let's go on to our next case. Thank you, guys. And this is a 9-year-old girl, and you can see her studies here. So she's very immature, still wide open triradiate cartilages, large cob angle, and the T1 to T12 length of 17.5 here. So I'd like to go back again, and let's start out with you, Greg. Are her lungs going to be okay if you do a definitive fusion at this stage? Do we need to keep her growing? 17.5, and Laurie Carroll's told us it has to be at least 18, maybe 22 to be able to get her to have good lungs. Where are we with this, and what do we know?
Well, I don't think we know much. I don't think when you look at Laurie's data that you really have an idea on what vertebral length means as it relates to lung function. And I think the one article that you've quoted is a good one as a starting point, but by no means should it dictate care. In terms of whether or not she needs to grow more to preserve her lung function, I would, this is where pulmonary functions will become particularly useful. If her vital capacity were 80%, and you really felt compelled to fuse her because of fear of complications, we might argue about that. I think for the most part, in a 9-year-old who's immature, particularly if her lung functions are at all compromised, I would worry about the loss of lung function as a result of fusion immediately after surgery and I would worry about the loss of future thoracic growth even during adolescence. So I'm a big believer that you fuse as late as possible, and that as long as you're doing expansions and you're seeing a preservation in lung function, you ought to continue along those lines.
And Greg, what does it mean, 80% in a 9-year-old who's still growing? Is that going to be 80% when she's fully grown, or is that going to be 20%? How can we interpret this?
Well, I don't think it'll be 20%. You can do some, if you look at lung function curves, just like you look at height curves, you can then replot it as if it's the same absolute value, and you're going to see clearly that it's less as a percent predicted as a child grows. It won't be 20%, but you'll lose at least 10 to 20% just by virtue of no further growth of the thorax. So again, this is age dependent. And I think the goal should be that you preserve as much lung function as possible, with the idea you may lose it after you age, after about age 25, as we all do, and lose lung function as a result of aging.
And then I'm going to go to the surgeons in the group here, and let's go back again. Lawrence, let's start out with you. What would you do at this stage for her? Defend diffusion, Vector, Sheila, traditional, magic? What would you do?
So first of all, aside from the lung function issue, which would push me not to fuse and to be growth friendly at this point, and I'm sure we've pretty much covered and I personally, I wait till their triradiates are closed and they're, a Sanders 4 to even think about that. The biggest issue in her, when you look at her x-rays, is her rotation. And the biggest issue with growth friendly devices in this age group is lack of apical control and crankshafting. So if you put a lot of traditional growing rods in the past in some of these children in this age group, as they get a little bit older, their x-rays look great on the AP, but they crankshaft like crazy. So I think this is a great case to think about apical control for a growth friendly device. Maybe think about a Sheila or trolley type device where you get some apical control. Certainly magnetically controlled rods are an option, but I think you have to be real aware of the deformity here and not just your AP and lateral measurements.
And Lauren and Courtney, if you could just put up the poll for this case too, let's get an audience response on this. And while we're doing that, I'd like to go on to you, Peter, and your thoughts.
So I think these are the toughest kids in this group to decide on what to do about. I have to respectfully disagree with Greg. I also don't understand completely the relationship between T1, T12 length and pulmonary function. But if you fuse this kid and correct them, they're going to be another 3 to 5 centimeters longer just by doing your correction. I totally agree with Lawrence about crankshaft in these kids. And that's why I think that traditional growing rods or even magnetic growing rods are a problem. So the question is, if you're a true believer in Sheila or trolleys and think that you can do them and get enough growth without fusion, then maybe that's this is the case for that. I personally am not such a true believer, and I think I would go ahead and fuse this kid. You're going to get the best correction you're going to get with your initial instrumentation and fusion. I think you can guard against crankshaft by instrumenting every level in a kid like this. And I think in my mind, that's the best option for a kid this age.
And Sumeet, your thoughts here.
This is my patient, and I agree with Peter. I always do shared decision making. I offer the family fusion with benefits of really getting the spine very straight, and also I think the risk of reoperation is not zero, but certainly a lot lower than with growth constructs. But we did discuss options of magnetic rods and Sheila, and I think those will certainly require repeated surgery. With our modern screws, posterior column osteotomies, high density construct, you can really make this look a lot better three-dimensionally with a fusion, even though she's 9. And her FVC was right around, is in the high 70s, I believe. So pretty close to that 80% forced vital capacity for age. But I would agree. I lean towards, I kind of told the family I'd probably be 60, 70 towards fusion and 30 to 40 with growth constructs.
And let me just jump back with what you said about her being at 70%, and we'll come back to you in just a second, Colin. Greg, I'm going to ask you again here. So 70% thoracic length isn't out that high. Are we going to gain anything by doing continued growth on her compared to doing a definitive fusion now?
Well, I know you're not going to get anything with a definitive fusion. So what you get is what you're left with. I think the question is whether you're going to get anything with continued growth. And I think that's an open question based on what people have said about rotation and deformity. It's not just a one-dimensional issue. And what Sumeet said, I think, is very important. If you have 70%, you're going to say, I'm going to leave you with less than that as you're an adult. If we had this discussion and this child had a 35% or a 40% vital capacity, I would suggest we would have a very different discussion.
And Colin, let's come on back to you now.
Yeah, so I think my decision would very much depend on how flexible the curve is. I think she's 9. She's still of a small stature, so I'd want to give her every opportunity to optimize her growth. So if this was a stiff curve, or if it was a stiff curve, then I would go for the Schiller construct, simply because it allows you to do apical osteotomies and get control of that apex as well. If it was a flexible curve, I would go for the magnetic growing rods, because our experience has shown that you're likely to get 3 to 4 years out of them, and that will take you into definitive fusion territory at about 12 or 13, when you can then do a definitive fusion. But I certainly wouldn't fuse her now. I think it's too early.
We have one question from the audience that we're going to go to, and it's how common is crankshaft? And let me just ask the surgeons here, very briefly answer common, uncommon, don't worry about it. And let's start out. Colin, let's go with you. We'll go in the backwards order here. Colin?
I don't think it's that common. I haven't seen enough of it to influence my practice significantly.
Sumeet?
I think it's probably more common than we suspect, but I don't think it's substantial enough that even if you get a little bit of crankshaft with high density screws, that it I think it often does not require any revision surgery. But I think it happens.
Peter? Dr. Sturm, your thoughts?
I think it happens, and I think that it happens more frequently than we think with growing constructs where we're fused and tethered at the top and the bottom, and they're still growing in between.
And Lawrence?
I think with high density screw constructs, it's a non-issue. With distraction constructs where we're fused at the top, fused at the bottom, then we frequently get a thin fusion mass in between. I think those are crankshaft machines in this age group. So I think in this age group, that can be a major issue. And one thing I'd like to throw back at Colin, if I can, is in this age group, with more frequent lengthenings with the magnetically controlled rod, do you think there's less of an issue with crankshaft?
Yeah, because I think she's the ideal age for a magnetic growing rod. All the ones that we have seen that have done well are around this age. So like I said, I think you need to establish whether that curve is stiff or flexible. If it's a stiff curve, then I don't think it would be suited to the magnetic growing rods. But I think our experience is that this age group do really well.
Well, guys, I want to thank everyone for participation in the audience, and I'm going to turn this back over to Lauren for the final administrative issues we need to do for cleanup here. Thank you.
Thank you, Dr. Sanders, and everyone for joining us today. Just note again that you will be getting an email next week about claiming your CME certificates. And if you wanted to watch this webinar again, it will be available on our SRS website in 1 week. Everyone have a good rest of your day. Thank you for joining us.
Thank you guys all very much.
You're welcome. Take care.